Good evening, good afternoon, good morning, depending where you're joining us. Welcome to this webinar being hosted by the Michigan Urological Surgery Improvement Collaborative. My name is Khurshid Ghani. I'm a professor of urology at University of Michigan and director of the collaborative, as well as the principal investigator of a large clinical trial that we are working on here in the state of Michigan and throughout the United States, called the Stent Omission after Ureteroscopy and Laser Lithotripsy trial. Today's webinar is going to be a focus on stent omission, and we're going to learn more about the trial. And as a practicing clinician, we want to teach you around some strategies and tips and tricks so you can implement stent omission in your own clinical practice. So welcome. Thank you for joining us. Let's begin. Disclosures are noted here. This study SOUL is funded by Patient-Centered Outcomes Research Institute, and music is funded by Blue Cross Blue Shield of Michigan, and my personal consulting relationships are noted on the slide. So we're going to talk about what the SOUL clinical trial is. Some of our faculty who are speaking today will speak about how providers may sometimes be concerned about stent omission and methods to address that. One of our faculty will be telling us how he implements stent omission in his clinical practice. We'll hear from an expert on maneuvers doing stentless ureteroscopy using the new, smaller, slimline ureteroscopes. And then we're going to hear from some of our surgeon scientists and other scientists in the field working in our clinical trial around views on stent use and other aspects about clinical trial engagement and methodology. I'm really grateful and excited to have an amazing faculty lineup of speakers, including John DiBianco from the University of Florida, Dr. C, my colleague here at University of Michigan, Dr. Madhu Gupta, MD urologist at Mount Sinai, Professor Ann Sales at University of Missouri, Dr. Stensland, who is a clinical trial expert here at University of Michigan, and my partner and the director of the Music Rocks program, Dr. Casey Dow, also a co-investigator on this clinical study. We're also grateful to have the input of two patient partners who will be joining us along, so we welcome them and we're looking forward to their insights. So why does this study exist? If you think about a routine operation, such as a 1 centimeter lower pulse stone, that you have a ureteroscopy, what we found in Michigan and throughout the US is that many patients complain of pain. And most of that pain is leading to unplanned encounters, emergency room visits, clinic visits. And what we found in music is it's the presence of a stent that can increase the risk of this happening. So what do the guidelines say for stent omission? Both the American Urological Association and the EAU guidelines state that if you do an uncomplicated ureteroscopy, a stent is not needed. But what is the definition of an uncomplicated ureteroscopy? Well, the AUA is very prescriptive on that. You can see the guideline statements here: stone size less than 1.5 centimeter, no suspected ureteric injury, all the other factors noted on this slide. And that, despite there being some guidance and some criteria, the reality is that many urologists, and especially in this country, in the US, around 80% of patients are routinely stented after ureteroscopy. So why? Why do urologists continue to stent, despite guidelines saying it's okay not to? I think one of the major reasons that we see is around the evidence. This is an important paper published in 2019, a Cochrane review from investigators at University of Minnesota that looked at the evidence on stent versus no stent after ureteroscopy. There have been around 16 randomized controlled trials done in this field. And they concluded that stenting may slightly reduce the number of unplanned return visits. This was different to the findings that we found in music, but what they did caveat is that the evidence is uncertain. And they concluded that higher quality and sufficiently large trials are needed to better inform decision-making. So it is against this background that the music team, where our whole we're a community where our purpose is to improve patients' lives, is we worked with patients and put in a funding proposal to the Patient-Centered Outcomes Research Institute. And we put together the stent omission after ureteroscopy lithotripsy trial with the hypothesis that the stent omission is associated with improvements in patient-reported outcomes and 30-day healthcare utilization. We are looking at stones less than 1 centimeter in non-pre-stented patients without using an access sheath. And this is the type of patient that we consider would undergo an uncomplicated procedure. This is a very unique trial. It's a combined randomized and observational clinical trial. Patients are asked to be randomized, but those who decline randomization, and we found from our patient partners that many patients would decline randomization, are still offered the option to be in the observational arm, which is very unique and has never been done before in this in the study of stent omission. Also very interesting and unique is that patients and surgeons are assessed by our scientists on the team for their preferences and their attitudes around stenting. So we're going to understand this much more as a result of this clinical trial. Our co-primary endpoints are PROMIS pain interference scores at 7 to 10 days after surgery, and also unplanned healthcare utilization within 30 days, looking at a composite tiered hierarchical metric of increasing healthcare utilization based on the severity. We are fortunate to have 17 centers across the US being involved in the study, and you can see all the sites noted here. And we began the study on June the 1st, 2023. We have enrolled 715 patients so far. That's been amazing. Our target is 931. And we are really close, and we hope to wrap up the trial the second half of next year. You can see that 37% of patients agreed for randomization. So this is the largest clinical trial on stent omission to date in the world, and also one of the largest prospective clinical trials in ureteroscopy. This study would not have been possible without the support, the enthusiasm of all these talented and amazing surgeons who are all part of our clinical trial. More than 40 surgeons are involved. This is phenomenal. And so I'm just so delighted to have this session today. I hope you enjoy it. I'm now going to pass it on to Dr. John Michael DiBianco at the University of Florida. John was our endourology fellow here at University of Michigan some years back. Was an excellent fellow and actually helped us at that time when he was working in music, help us brainstorm and design aspects of this clinical trial. So I'm just so delighted that I can hand over the first talk to John, who will tell us about his feedback as a clinician enrolling in this trial at the University of Florida. Thank you, John.
Thank you very much, Dr. Ghani, and thanks for the opportunity to talk about tips and tricks for stent omission. As Dr. Ghani may have mentioned, I'm John Michael DiBianco, endourologist at the University of Michigan and co-director of the BPH program. So my story, I was born and raised in Washington, D.C. I did research at the NCI, went to Ross University for medical school and George Washington University for residency. And I had the pleasure of training under Dr. Ghani and Dr. Gao here at the University of Michigan for my endourology fellowship. And at George Washington, I had the opportunity to learn from Dr. Patrick Mufarge. And I was taught there that stents are very good. So we stented everybody all the time. When I got here to Michigan, I learned that stents are very bad. And we practice stent omission quite often. So when I was trying to figure out what am I supposed to do in practice, this was me. I was sort of a bit confused about how I should proceed moving forward. So what did I do? I went to the guidelines. And so the guidelines say that we may omit stents in uncomplicated ureteroscopy. The AAU is a little bit more assertive, saying that you do not need to insert ureteral stents when it's an uncomplicated ureteroscopy. And the UK says that stent omission is indicated in for patients and procedures that are treating ureteral stones less than 2 centimeters. So my stenting algorithm and stenting options became short-term stent, long-term stent, and then stent omission made an appearance. And so what I learned in practice was the best way to start is to just start. So just doing it. If you don't start doing it, you're never going to feel comfortable enough to do it. And luckily, at the University of Michigan, they came up with some criteria for how to guide which patients to omit stents on. And so in particular, pre-stented patients with less than 1.5 centimeter stones or non-pre-stented patients with 1 centimeter stones in the uncomplicated ureteroscopy were the patients that I focused on. So then I joined a practice at the University of Florida. Now, when I got here, I was very excited and wanted to kind of gauge what the culture was about stent omission, whether that was something that was done. And I soon found out it is not what is done at the University of Florida. So the culture was for stenting, which is pretty common. So then I had to figure out, do I do what I feel is right for patients, or do I try to conform? Because I don't want to be the guy who caused my colleagues to have to come in the middle of the night to place a stent because the new guy did not put a stent in a patient they, in their eyes, would say they should have. So how did I start? So I identified the relatively easy ones. So the chip shots, the pre-stented patients with large ureters with smaller stones, avoided complicated patients, patients with recurrent UTIs or UTI history, blood thinners. And I also gave patients my number, not always my cell phone number, potentially a Google number, which I could always change and cancel. But I wanted to be the one to know about any issues first before my colleagues or anybody else was aware of them. And so here's my technique. We've been doing this for quite some time, for a little over 3 years now, and knock on wood, things have been going quite well. So preoperatively, I get a urine culture on everybody. I write everybody, if they're not already on an alpha blocker, for Flomax or for 30 days, and I instruct them to start it 10 days prior to the procedure. I give them the music information about stents and about ureteroscopy, and I discuss with them. Intraoperatively, if they don't have a stent in already, I will go directly in with the ureteroscope. I usually use a safety wire, usually a zip or glide wire. I'll come back out and I'll go back in and atraumatically enter the ureter and hopefully perform an uncomplicated dusting procedure, grab a piece of the stone on the way out. And if everything has gone well in an uncomplicated fashion, I will omit a ureteral stent. Post-operatively, they all get the music cocktail, the music educational material, and they continue to take that 20 days that they have left of the alpha blocker. And so these are my endourologist colleagues, and I'm happy to say that 90%, if not all of them, have performed stent omission since me getting here, and some of them perform it quite often. So knock on wood, we're doing quite well with that technique. And so in conclusion, what I'd say is that stent omission can be safe. It is possible to learn. I myself was not at all comfortable doing it prior to my fellowship. I would definitely say start with the easier cases, the less complicated cases. Education of your patients is incredibly important. They need to be a very active participant in this process. The use of alpha blockers, I think, is very helpful. One, for stent discomfort when they have to be placed, also for preparing the ureter for an uncomplicated ureteroscopy, and potentially for the assistance in the passage of dust. I would definitely say be available. If you're at a culture or practice that this is not typically done, you want to be very available so that you don't seem like you're doing anything negligent or new or dangerous to your colleagues. And track your outcomes. I have an epic list that I keep these patients in, and I want to be aware if there's any issues and if I'm doing maybe my criteria for selection is incorrect. But with that, I'm going to hand it off to Dr. Wilson Swee, and thank you very much for the opportunity.
Thank you so much, Dr. DiBianco. I'm here to give a little bit of an opposite perspective on stent omission. My name is Wilson Swee. I'm an assistant professor here at Michigan. And so just a little bit about myself. I grew up in the Northeast and then did med school down in the Northeast as well before going to Nashville, where we had our daughter, and then the West Coast, where we had our son, and then finally ended up here in the Midwest for an attending job. And I have that sort of long-winded introduction because really this was the paradigm to stone surgery. It was, after all, why not? Why shouldn't I put in a stent afterwards? And here are some of the people I trained with. And one of my co-residents, Dr. Hall, who's here in Michigan with me, can back me up on this, which is that we just sort of stented everyone. And stent omission never really came up until I joined the staff here. And here are some of my many esteemed colleagues. And within the first few weeks of me starting here, they said, why do you stent everyone? What are you doing? One of the pieces of advice I got before starting as a faculty was to trust your training. So that put me in a very sort of interesting position where I started, we started talking about stent omission and it was almost part of the culture here. But where I trained, we really didn't talk about it too much. And so I had sort of a stent dependence issue. And so here's a 5-step program that has really helped me become better about stent omission. Step 1 was admitting I have a problem. And so how did we find that out? Well, in counseling our patients here, I tell everyone, hey, so at the end of the ureteroscopy, we'll put in a stent. And in fact, there's so much stent omission going on. This is an actual quote from one of my patients who said, hey, yeah, but, one of your colleagues, Dr. Mansour, across the seat, says he does not put in a stent at the end, and we didn't do it last time. Why can't you do the same thing? So coming in from outside of Michigan, you sort of are a kid in a candy shop looking in on how things are going. When you're actually here and you're involved in music, you really get to see and feel this sort of indirect peer pressure of, hey, everyone else is doing this, or a lot of other people are doing this thing. Why aren't you doing it as well? And so that has been another way for me to recognize that, hey, maybe this is a problem. Maybe this is something that I shouldn't be doing anymore. Step 2 is recognizing the harm. Well, you can look at the data, and this is sort of a well-trodden slide where that showed Dr. Hiller and Dr. Dow, Dr. Ghani's, some of their seminal work on this, which was that patients who had stent placement after urology tended to come back to the ED at a higher rate. And then so I started really talking to patients about this. So, and this is another real quote where I'll say, so at the end, we put in a stent, and one of my female patients said, I would literally prefer to have anything else other than a stent, even have another kid or 2. Step 3, data therapy. So here's some of the unpublished work we had from AUA from this past year showing that, before and after the value-based repayment, the stent omission rates really did go down here in the state of Michigan. But the question was, did the ED visits change at all from that? And no, we still saw that not putting a stent led to lower ED visit rates, even though we were not stenting more people, which was reassuring for me to say that, hey, even though we're probably being more aggressive about stent omission, we're not really increasing the risk of patients coming back to the ED. Nonetheless, it's still challenging. You see in the stent naive patients, it's still a harder population to really stent omit for. But if we look at some of our other data, and this again was shown at AUA this last year, in terms of access sheath placement, well, even in patients that are pre-stented, a fair bit of them don't go on to get a stent afterwards. And then in the non-pre-stented patients, there's a minority, and this is probably consistent with most people's practices, who don't get a stent afterwards. But again, we still find that people who don't get a stent tend to come back to the ED with a less risk than the people who do get a stent. And sort of the proof is in the pudding. I remember the first time I did this for someone, and it goes against all the training I ever had in urology. And I said, hey, like we talked about, I didn't put a stent in. And the patient said, hey, can you just give me apple juice? I feel sort of good right now. This is the best surgery I've had in a while for kidney stones. And those positive instances have really helped for me reinforce the benefits of stent omission, even as soon as seeing someone in the PACU. I think that finding support is important, and that's part of, this is a scene from The Matrix, freeing your mind. And in this case, it's freeing your mind from needing to put a stent in everyone. Part of it was finding very supportive colleagues. Part of it was having the privilege of putting people into a trial and to lean on that and say, hey, I'm putting you in a trial. That's why we're doing this. And it's been working for other people. And certainly having, my colleagues every week when I come back with no patients enrolled in the trial, giving me a grumpy face helped with some of the incentive too. I think other things that have really helped is really trying to optimize people beforehand. And so this is a nice review paper on the benefits of alpha blockers before ureteroscopy. And it really showed that there's decreased, negative ureteroscopies because you couldn't get the scope up and the need for dilation. No touch, this is something I was doing in training, but I think this has certainly helped me get away, or at least mentally get away with feeling better about not putting in stents in patients, especially when you can navigate the ureter pretty easily just with one pass with a ureteroscope. And then technology, as scopes continue to get smaller, are we going to feel more comfortable with not putting up a stent afterwards because the ureter is easier to navigate, because you feel like you're doing less trauma, I think is also hugely beneficial. And step 5 is really just embracing the stent-free lifestyle. I will admit not everyone is stent-free. I don't stent omit in everyone, but things that have, again, really helped is enrolling people in the clinical trial. Even when I do minor dilation, I feel comfortable putting no stent in. And then in the pre-stented population, this is easier. But even now when we're putting a sheath up, oftentimes I don't put in a stent afterwards. And we have a randomized trial out now on that we're accruing for. And similarly for patients that come in with infection or were infected beforehand, I think the Delphi panel that music has run for that has opened my eyes in terms of antibiotic practices. And, it's sort of, as a new faculty, it's sort of you're a dog on your own leash and you're leading yourself. And so for me, it's one case at a time, really trying to push the envelope on stent omission. And here's a nice summary of the 5-step program, and I hope it helps people. That's all I have. Thank you. And now it's time to turn it over to Dr. Dow.
Thanks, Wilson, and John Michael and Kershid for kicking us off. It was a great start to the webinar tonight. So I have the pleasure to be joined by a patient advocate, Janice, who will kind of gear much of the discussion towards, as well as Dr. Swee, who just gave that great presentation. And so, Janice, thank you so much for being here with us today. I think what's really unique about your story, and I'd like to hear a bit more, is that you are actually a sole trial patient. So you're intimately involved with how this all works. Can you tell me a little bit about your experience in the past with kidney stones prior to your enrollment in SOUL?
Sure. Well, first of all, thanks for having me. It's a pleasure. I had previous experience, 3 stents placed prior to my last experience, so 4 stents in total before I was part of the trial. Not good experiences, did not like having the stent, very uncomfortable, painful, frequent urination, painful urination, stressful, knowing that it was there and it was going to have to come out. It was uncomfortable, just all of them were like that. And when I went into this latest experience and they asked me if I wanted to be part of the trial, of course I didn't want to have another stent.
Yeah. So I guess that's the most interesting question to me potentially is, based on your prior experiences, what were the factors that led you to be willing to be randomized, right? A coin flip between stent placement and stent omission.
I guess when I thought about it, I thought if I was going to participate, I was going to do what was best for the study. So if I was going to agree to do it, I might as well do it right. So you could get the most information that you could out of my experience. And
so I know your case, but tell us then. So you show up for surgery, you're crossing your fingers that you're going to be in the 50% no, but what happened?
Well, I got it. I guess it was my lucky day. So I got the stent and you just deal with it. I wasn't real happy about it, but it was the luck of the draw.
Did you feel like one of the things that John Michael said, the University of Florida urologist, in the first talk that we had was how important patient education is related to a stent. So if you think back now, you've had a stent 4 times, right? Do you feel like there's been any evolution in your education around stenting, and hopefully that in enrolling in the SOUL trial, though you had your own personal experience, that we might have done a better job of educating you as to what we could do to mitigate stent discomfort if you were in that group?
I believe so. And part of that might have been just too having the experience and learning a little bit each time. But I do feel as though my concerns were addressed and I was listened to, that I was at least given the option of whether or not I wanted to participate in the trial. Mm-hmm. I felt when I first started experiencing kidney stones, I really was just kind of at the mercy of whatever they told me I needed to do. And you trust your doctor and you do what your doctor says. Yeah.
So another question I have that came up from John Michael's talk and was discussed a little bit in Wilson's talk is this notion of, we're fighting inertia here as urologists. A lot of our practices are ingrained because of years and years of training, and those people that trained us had years and years and decades of training. What are your thoughts and feedback around the idea that the urologist might give you his phone number, whether it be a Google number as suggested or their personal cell phone number? Have you experienced that before?
I have not, and I like that idea. Just because it's new to most people that experience it don't know all the questions to ask right from the get-go, and they're going to run across some situations where they'd like to ask some questions. And I think for me that would have been helpful.
Yeah. So
one of those 4 times.
A couple of the urologists that retired from a group that the University of Michigan acquired were really consistent in doing that for all their patients. And I remember, much like John and Wilson were shocked that we were stent omitting, I was shocked that you would give up your freedom essentially to give a patient your cell phone number. And their comment to me was, the patient's only going to call you if they absolutely need to. And that's it. And so I have tended to do that a little bit more in my practice. And I think that that's a really good point that was brought up by John Michael. So in the couple minutes that we have left, and Wilson, chime in for sure if you have any questions that we haven't addressed. What was your experience like this 4th time? You wake up, you're randomized to stent. How did things go?
Well, I had a lot of the same symptoms I had the first 3 times, where it just was uncomfortable. I was disappointed, of course, because I was hoping that I was going to go without the stent. And I think the stress just started to build of knowing it was there and it was going to have to come out. And I just didn't like that idea. That was more stressful to me than whether or not I was going to get it in the first place, I guess. I just didn't like the idea of knowing it was there. And it was uncomfortable.
Yeah, well, I mean, what I can say is these sorts of interactions with patients like yourself, for sure, kind of color our feelings about enrolling and participating in this trial. I think it's pretty powerful that you were willing to, submit to the coin flip, so to speak, because of the, benevolent reasons, which is to participate in a trial that may answer some of these questions. And so I, for one, appreciate it as a co-investigator. And I think, we'll hear from Dr. Kevin Tim later in this webinar, also a patient, that similar feelings are shared by other folks that are involved in this trial. And I think, the hundreds of people that have been willing to participate to this point. So, Janice, I think that you're a rock star for the trial, and hopefully that's the last kidney stone event that you have, or the trial will be closed and Dr. Ghani will just not put a stent in. So with that, thank you so much for your participation and your insights here. And I'm going to turn things over to Dr. Mantu Gupta, who's going to be discussing a novel small ureteroscope to facilitate stent omission. So take it away, Mantu.
Thank you.
It's my pleasure today to talk to you about stentless ureteroscopy as facilitated by a 6.3 French ureteroscope. These are my disclosures. The rationale for using a smaller ureteroscope to allow stentless ureteroscopy is clear. The need for a postoperative stent is related to trauma to the ureter, and a smaller caliber ureteroscope requires little or no dilation of the ureter, and theoretically there should be less trauma. The newer 6.3 French ureteroscope design has the same working channel and deflection abilities, and so it should allow us to achieve the same surgery we're doing with the larger caliber scope, just with less trauma, therefore less need for a stent. Potential harms, of course, of any new device are failure to achieve the desired outcome and the delayed need to stent in certain situations. So I'm going to present to you a few cases that we did. First one was in the office, and the others in the ambulatory surgery suite that we have using the 6.3 French scope. In all these cases, we were able to do them stentless. All these were performed by myself using a UGEMED 6.3 French flexible ureteroscope. A thulium fiber laser was used when performing laser procedure, and 2 French bug bee for the office tumor ablation, as you'll see. And all procedures are done outpatient, totally tubeless basis, as mentioned. So this first patient here is a patient who's had bilateral upper tract urothelial carcinoma that I've resected in the past. In the office, I'll do surveillance ureteroscopy on these patients. So here I went up to the right collecting system, inspected it. You can see that the view, with the digital quality of the view, is excellent. And now we're going down the ureter and observing for any tumors. We observed on the way up. We also observe on the way down. And because we're using a no-touch technique, we can identify carcinoma in situ and even subtle disease very nicely. And you can see that the image quality is excellent. You can see blood vessels. You can see the entire lining. Because we're not using a larger caliber scope, not having to dilate, it's easy. Now we're going to the left side. You can see all we do is just swing our ureteroscope in the bladder over to the left ureteral orifice. And once we identify it, we try to adjust our ureteroscope position to be able to get up the ureter easily. You always want to go through that little flap at the UO. Now we're going up the ureter. And you can see we're not causing any trauma as we're going up, and we're going up under direct vision. So we're slowly making our way up the ureter because the purpose here is to make sure that there's no disease in the ureter. Once we reach the kidney, we explore the kidney. We turn our scope. You can see that one-to-one torque ability of this scope is excellent, making it easier to see all the calyces. We're visualizing calyx by calyx, making sure we map the entire collecting system and make sure we don't miss any lesions. And you can see this whole procedure took just a couple of minutes here. Now we're in the bladder, and there was a tumor that we had noted initially when we got into the bladder. And there's a tumor there that we're ablating with the same ureteroscope. So there's a 2 French bug bee electrode. It's done in the office. You can see you get excellent hemostasis and a thorough ablation. And you can do the entire procedure with the ureteroscope, which is a big advantage. So this is basically what the ureteroscope looks like. And I'm demonstrating here a couple of features. One is there's a toggle on the ureteroscope that allows us to swing side to side, as well as doing the normal deflection up and down. So you can get different permutations of this ureteroscope that you cannot get with some other ureteroscopes. Now here's an example I'm going to show you of an impacted ureteral stone. This was done in the operating room with gravity irrigation. So often with these impacted stones, you can see this is a spiky stone. We try to push the stone and disimpact it. In this case, this stone was too stuck. We couldn't. We put the patient in reverse Trendelenburg position so the pieces don't migrate up to the kidney. And we laser the center of the stone with the TFL laser. Now, the TFL laser has gotten a bad knock, sometimes saying it causes more ureteral trauma, but I think that's more related to settings and to technique. Staying in the center of the stone under direct vision here with this small caliber ureteroscope, you can see the vision is excellent, and we can fragment the stone with pinpoint accuracy. We're able to take each of the little pieces that have broken off the main stone and pinpoint the center of the stone and hit it with 1 joule 2 hertz, which is my typical setting for fragmenting stones. And I'll keep going and getting the pieces smaller and smaller and smaller and smaller in the reverse Trendelenburg position, because the vast majority of these fragments will wash out of the ureter. The nice thing about having a 6.3 French ureteroscope is there's a lot of flow around the ureteroscope, and you can see that, all the fluid that's coming back around me and going down to the bladder. So even when we're using gravity irrigation, we're getting a continuous influx of urine fluid, into the collecting system. Now here we are basketing a piece of stone. You can see that there's excellent flow even with the basket in, because the working channel is 3.6 French. And really, the size of fragment you can remove is the same with this scope as any other scope, because that depends more on the caliber of the ureter. So we grab the stone, we come all the way out, and we put the stone in a basket, and then we go right back in through the urethra. And you can see, even though this is a male patient, it's really not that difficult to negotiate the urethra with a small caliber ureteroscope. The vision of the ureteroscope is almost like a regular cystoscope when you're going through these areas. And you can see there was another fragment there. So pieces are already coming out without us having to do anything because of the reverse Trendelenburg position. Now we're going to go back up the ureter. You can see that it's not that difficult to go back up. And there's some remaining fragments here. And this one is a little bit too big to come out by gravity alone. So we'll grab it, we'll pull it out, and it'll actually drag some of the other pieces along with it, like that. So we'll put that into the bladder, and then we repeat the process until the entire ureter we are sure is stone-free. That is a very spiky stone, typically dihydrate, so they cling a lot more. So it is very important to get every piece out, because you don't want to leave one of those clingy pieces around. And at the end, we always do a final ureteroscopy and pyeloscopy to make sure we haven't left any fragments inside the patient. So this is just a typical example of a totally tubeless ureteroscopy facilitated by a small caliber ureteroscope, in which case we don't use a guide wire and don't use any fluoroscopy and don't have to leave a stent in the patient. This is our final exit here out of the patient. So hopefully with these two examples you've seen now in the office as well as in the OR, you get an idea about the usefulness, utility of this scope. So in summary, a stentless small caliber ureteroscope is feasible in the office or in the OR. The outcomes are similar to the same procedures performed with larger caliber scopes. There's minimal complications. They save time because you only need one scope for the entire procedure. There's minimal trauma to the tissues and minimal patient discomfort in the office as well. It decreases healthcare expenditures. And I think in the future, the smaller caliber ureteroscopes will replace the larger caliber ureteroscopes because there's really no downside to them that I've found so far in the cases I've done. Thank you. And I'd like to now turn it over to Dr. Casey Dow for the question and answer session. Thank you.
Thank you, Mantu. As usual, an incredibly innovative and progressive talk. Thank you for participating tonight. So I'm joined now by Dr. Gupta, Dr. Khurshid Ghani, and Dr. Wilson Swee for this next period of panel discussion. And so maybe where I want to start just from a high level view, Mantu, is reflecting on the first two talks that we got. What do you do, or how have you approached the idea that, you know, some of your colleagues may be uncomfortable with stent omission, and what were your reflections on the talk that you got there, specifically as it relates to working with your peers?
Yeah, I totally get it. And I think Dr. DiBianco's comments that he didn't want to burden his colleagues with emergency room visits and calls to the office in the middle of the night and the weekends. He's trying to save them from any, undue work that wasn't necessary if he had stented someone. So I think that's the fear. I think that's probably the number one fear I see in my colleagues at my own institution doing it. And the only thing I could say is you just have to jump right in and start slow, start with the easy patients. I think the pre-stented patients, the protocol you have in Michigan, I think is wonderful the way you started it. And Dr. Sweet talked about how he transitioned from stenting everyone to decreasing the number of stents following that protocol. So I think that's key, to have a formal plan in your mind of how you're going to progress to doing stepless ureteroscopy.
So kind of a segue from that, maybe Khurshid or Wilson could chime in. We did get some questions from the chat. One of the questions came from Jay Lonsway, one of our excellent partners here in the state, is how atraumatic is atraumatic? And I think it's a really interesting question, right? Because my definition of what that might be might differ from Khurshid, might differ from Mantu, et cetera. So Khurshid or Wilson, what can you take that one?
Yeah, I'll start here. I have to say, it's really rare for me to even dilate the ureter. So, and I have an 8-10 dilator. It's rare. And I am absolutely convinced, and I credit Dr. Clayman from UCI Irvine for this. Like, he's saying that he puts alpha blocker and he can get access sheets up easily. Opened my eyes, and there's been multiple RCTs on this. So every patient in my ureteroscopy protocol, they are on an alpha blocker. And since I've done that, I can get a ureteroscope. I think I'm not using a large caliber ureteroscope like a 9.4 French, but definitely on the 8 French size and sometimes under. So it's really rare. If I do dilate, then I have to admit that most of the time that is just a tight ureter globally, and I'm placing a stent. So that's my experience. And I think because I've been moved into the alpha blocker pathway for the last few years.
Yeah, I think enrolling patients onto SOL has really opened my eyes in terms of what you can get away with in terms of dilation. And as a part of the inclusion criteria, I know we allow up to 8-10. And so the first time I did it, I was really nervous. I said, hey, I'm going to do this. I'm going to get the scope up, treat the stone, and leave this patient or randomize them at the end of it for stent omission, yes or no. But it's really by virtue of participating in the trial that I felt, okay, this is part of a trial. We actually don't know the answer here. And so it's okay to do this. And so that helped me at least get over the mental hurdle of that.
So Mantu, I see, I share your enthusiasm for the 6.3 French scope. How have you changed your practice in light of some of these more affordable, disposable ureteroscopes?
They may be affordable, but our hospital still hates when we use them. They want me to use a reusable scope every time. And then we have to fill out a form every time we use a disposable scope. No matter how much I try to convince them that it's financially advantageous to use a disposable scope, they just don't buy it. They looked at my numbers and they say, well, you know what? When you use a reusable scope, you're only costing us $300 a case. And I said, well, that's because I have a good ureteroscope, I use a Flex X2. It's very durable. And I may get more cases out of it than the other person. But still, you have to factor in other costs that they're probably not doing, sterilization and everything. Going back to the dilation point, with the 6.3, I've never had to dilate anyone using that. So my protocol generally is I will use a reusable scope. It's a 7.5 French scope. If it does not go up, I'll dilate to 8 and then to 10, because 8's not enough to get the 7.5 up. You need to dilate to at least 10. If the 10 goes easily, and I don't have a sense for that. I know Ralph Clayman says 8 newtons is a force, but it's cumbersome to use a force gauge or some of the things he's described. So I don't do that. But if a 10 goes easily, that's a patient, even though I dilate to 10, I'm not going to stent them. I'll put the 7.5 up. And if I don't have to go above 10 because I'm using a 7.5, so there's no point. So I know you technically can go up to 12 kc, but I have never had to do that because I'm using a 7.5. And if the 7.5 won't go up, then I'm using the 6.3 French scope because that'll go up the ureter almost always. So that's our general protocol. That's how I limit the use of the 6.3 and keep the OR happy.
Okay. Can I just add on that thread, Mantu, which is I've been using more and more of the slimline, the 6.3, like Casey has, like Wilson in our group. And I think the whole flow of the operating room is much faster. So I think that's something that we should all look at, is like, how many patients can we get through? How quicker is, I've heard from the nursing staff already that what they have to open up in the sets is quicker. The turnover might be slightly quicker. So I think there may be an argument with the health systems, Mantu, if you can study this, to say, hey, I can get more cases in. You only need to get 1 or 2 more patients in extra. And I think that definitely offsets.
You're probably not using X-ray, which also helps.
Yeah.
Because X-ray take up time to use.
And personnel staff as well. Yeah.
Wilson, have you shared similar experiences with either the 6.3 French or 7.5 French disposable ureteroscopes?
Yeah, I mean, it's interesting. When we first started using them here, a few of the residents said, "Oh my gosh, this is like so light. Do we have to go back to using this other scope?" And I say, "Yeah, we should be, environmentally conscious and do it." But I fell into into just getting used to using more of the disposables. And part of my training, we used a lot of disposables too. And so it's hard to go back once you start using it ergonomically. It makes sense. And like Montu mentioned, facilitates floorless ureteroscopy. And so there's a lot of benefits to it that may not be so easily capturable on a pen and paper.
Yeah, and I completely echo, Kirsty, we had that side conversation even today. In a scenario where turnover is often the limiting factor for us, not having to make sure that a tray that has your cystoscope, because it's not needed if you're using the 6.3 or 7.5 is present. Really, it's really minimized what we need to open for each of these cases. Have everything available for safety, but I think there's no doubt that could have a benefit on turnover, and that may flip the value, argument completely on its head. So, with that, thank you to our three excellent panelists and Montu for that excellent talk. I'm going to be turning things over now to Dr. Ann Sales, who's going to be talking to us about patient and urologist perspectives that we've gleaned from the trial thus far. So thank you, Ann.
Thanks, Dr. Dow. I'm Ann Sales. I'm a faculty member at the University of Missouri in the schools of nursing and medicine. And the work I've been doing related to the SOUL trial is qualitative interviews with both surgeons and patients, in which we've been talking about their experiences and some of the issues and factors surrounding decision-making. This is titled "A Necessary Evil versus Only If There's No Alternative," which represents the predominant view coming from surgeons that stent use is a necessary evil in routine ureteroscopy, and patient views that they would, in general, prefer to have stents used only if there is no alternative to using the stent. I'd like to briefly thank the team that's been working with me on this. These are all graduate students and graduates of this PhD program at the School of Nursing at the University of Missouri: Krista Teresi, Cassandra Bocciarino, Brittany Marks, and then myself. So what we've been doing is conducting interviews with surgeons and patients about their routine ureteroscopy, their experiences, and the use of stents. We've completed 29 interviews with surgeons. We are continuing our analysis with surgeons. And our goal has been to interview all the surgeons who are participating in the SOUL Music trial. Among patients, we've completed 20 interviews. We have completed our analyses of those interviews. And our goal is interview patients, because that's well over 500 at this point, but instead a sample of patients who underwent ureteroscopy and consented to participate in the trial. We're also conducting a survey of all patients enrolled in the trial, and that survey is currently underway. So let me talk briefly about the themes that have emerged from the interviews. On the side of surgeons, where we've mostly asked them to reflect on the factors that affect their decisions about using a stent, we have heard repeatedly that stents are regarded as a necessary evil. As they present the plan for surgery and for the procedure to patients, they focus on managing expectations. And the majority of surgeons participating in the trial say that they stent between 70 and 90% of all patients undergoing ureteroscopy. We have interviewed a couple of surgeons who are low outliers, who say that they only stent about 10 to 20%. The issue that surgeons have reflected on repeatedly in their interviews with us is that they don't know what they'll encounter during the procedure, and that they have, in general, significant anxiety about potential poor outcomes if they don't use a stent. On the side of the patients, as we've interviewed them, most, not all, but most have expressed a very strong preference for avoiding a stent, only if there is absolutely no alternative. And for most of them, the major issue is pain. In addition, they've discussed the need for more education and preparation than they feel that they've received. Many of them seek information from the internet, from friends and family, but also from their own previous experiences. And most have very strong preferences about stent removal, as well as whether or not they receive a stent. Most patients have expressed that they did not feel that they got enough information about stent removal. One of the things I want to stress, though, is that most patients in this trial were willing to accept randomization, and this is mostly out of a desire to help future patients. So to summarize, this is a very brief overview of what we've been learning from our interviews. Both patients and surgeons see the experience of ureteroscopy very differently. Surgeons focus on the technical issues, and patients focus on the pain that they experience. It is a painful procedure, and they're in pain while they have kidney stones. Most surgeons know that their patients would prefer not to have a stent, but they feel that circumstances during the procedure require it. And most surgeons focus on managing expectations. They also express a concern that predicting whether a procedure will in fact be routine when it should have been routine is not easy. And these are issues that we will continue to consider and reflect on as the trial continues and as we begin to look at the preliminary results. And I'm now going to turn the podium over to Dr. Christian Stensland. Thanks.
Thanks so much, and thanks everybody for tuning in. It's really exciting for me to be able to talk to everyone about some of the approaches that we've been trying to take to both design and test how we improve the clinical trials run within music. To kick things off, in terms of disclosures, I have some unrelated financial disclosures, but a lot of this work has been funded by the NIH and the Department of Urology at the University of Michigan that I'm very thankful for. So we're going to kick off with two main questions today. And the first one is why care about clinical trials in general and specifically how they're run within music, and also why we should care about how we run clinical trials. And the rationale behind this is to really try to provide the best care for patients while also making sure we're minimizing all the negative impacts on the music stakeholders, including patients, of course, but also all of our urologists. So the big question here is why should we care about trials? Now, of course, we know that well-designed trials can answer very real questions. Specifically germane to today is should I leave a stent or not after uncomplicated ureteroscopy? And the big issue here is that often without a clinical trial, we don't really know what's accurate. So while we have great retrospective data, even the best retrospective data, including from music, often can't replace a clinical trial. And we really do need a lot of this prospective data to answer questions where other confounding factors make it so we can't necessarily rely on those results. But in addition to these issues in general, there's a specific benefit to music specifically for running clinical trials. And part of this is that trials run in music can really reflect our own community's needs, and we can open trials that match specifically our own issues. Additionally, music data can guide our questions and also can help us pick which sites should run trials. So specifically, some of the trials that I've been involved in and we're running include the SOUL trial. We observed previously that there are higher ED rates for stented patients, but we needed to prospectively test this. We do know that this actually applies to our patients because of existing data, though. And similarly, when we go to pick which sites to run our trials in, for example, in our Brian trial that we're sending into PCORI in the next cycle, we saw that there was some variability in what the benign nephrectomy rates were, and some sites had lower benign nephrectomy rates, and it really impacted how we're designing that trial and which sites to put in it. On top of this, once we get the results from clinical trials back, these results from the trials that are run specifically in music should apply very well to our own patients. My past patients, for example, probably look a lot like my future patients, but also patients from other music sites are probably going to look more like mine than trials that are run in other settings like Denmark, for example. We also can find that we can implement the results directly in music afterwards. So once we know what works, we can roll it out pretty fast, and we can use our music tools to get the right thing to the right people at the right time. And you may say, fine, I bought into the idea of clinical trials, but why should I care about how we're doing the trials, as in how are we implementing them? And specifically, one of the things I wanted to focus on is about clinical trial enrollment. So many folks have participated in the SOUL trial, and trial enrollment is actually really hard. And this is true internationally. Enrolling to trials is really the hardest part, and about 1 in 5 clinical trials will fail, mostly because of these issues with enrollment. And few trials ultimately complete enrollment in their planned time frame. time. And the big question here is how do we fix it and why do you care? Unfortunately, despite over 75 years of clinical trials, nobody knows how best to enroll patients. And most ideas on how to enroll better are never actually tested, and very, very few are tested in their own randomized study. So what we end up with is we roll things out, but we don't actually know whether they're effective. And so if we do things just kind of ad hoc, we're not really going to be sure that what we're doing is making a difference and is it worth the effort. So for example, there's a really simple fix, or there are a few simple fixes, one of which we tried within the SOUL trial. And the question here is can we just lean on music communication, kind of our existing music infrastructure, to improve enrollment to trials? And one way about this is like, can we just increase our direct emailing to folks about the trial, the same way that you advertise the collaborative meetings and that type of thing? And my question here is do you remember Soulvember? Back in November, we launched this campaign that you may remember in your inbox that was advertising for an enrollment push within the SOUL trial. This was a great thematic and entertaining emails, but also leaned really heavily on behavior change research that was looking at things like leaderboards and feedback and doing some packaging of advertising materials to try to improve enrollment, which makes a lot of sense. And so it makes sense that it would work to improve enrollment. But the question is did it actually? Anecdotally, yes, it did. 32 participants enrolled during the push. And the question is was this more or less than we'd have had anyway had we not sent out all of those emails? Unfortunately, there's fewer participants than October, but it's hard to compare month to month, and the same participants as we enrolled in December. But again, number one, it's hard to tell based on the temporality how folks are enrolled. And also there are lots of other things that are going on at the same time, similar to a lot of the other initiatives that we do within music. In addition to these targeted emails or trial-wide emails, there are individual emails and other individual communication like text messages or just face-to-face chatting about trying to push for enrollment, as well as things like the collaborative-wide meeting in October. So it's really hard to disentangle, was it our specific email push that worked or these other things? And you may say, why do we care? It's just an email campaign. It's relatively inexpensive, but why do we care? One reason is that it takes time to generate and send emails. Even for something that's relatively low cost, it's not zero cost. The other thing is if email advertising doesn't work, we don't want to clog people's inboxes, and we also don't want to distract from all the other great communication we have. So the question is how could we know if it works? And the easiest way is just to do it again, but this time we should control and measure how we send it out, which brings us to our actual intervention, which is the core of tonight, which is we launched this Soul Madness campaign in the month of March. This was thematic. You may recognize these from your emails. And this was, again, advertising around theming and enrolling into the SOUL trial. But the question was how to send it. And what we did was we split all SOUL providers who had enrolled folks into the trial into two groups randomly. And we paired them so prior enrollment was similar between groups. And then we sent the first group advertising emails for 4 weeks, and then we rolled it over to the other. If you're interested in the protocol for this, we just recently published it. And the big question is did it work? Within the month of March, the email groups, the folks who were sending weekly emails to, enrolled 9 participants compared to 7 in the control group. So a minor difference. But then when we flipped it, when we started emailing the other group, they only enrolled 2 participants versus 5 in the control group. When you lay out how this looks, Group A was the first group who got emails, and Group B is the second group that got emails. And so focusing in here, you can see when we launched our trial from February into March, there was really no difference in enrollment. And then when you compare this back to Soulvember, we also see that there was really not an impact at that point. As far as the current analysis goes, there's really no difference between these groups and enrollments, but there are unclear secondary benefits, like maybe higher morale or engagement and some longer term benefits to enrollment. But limitations of this are small sample size and a short duration. We're still working on some next steps, including evaluating engagement, checking email receipts, and comparing to eligible patients to find out about absolute and proportional enrollment. We have a few next steps, including refining our messaging, getting some feedback from everybody on what messaging is helpful, and evaluating our engagement, including trying to find other strategies to promote enrollment and identify and overcome other barriers. And as a final closing point, we can also apply this to other interventions prospectively in music, and we're trying to build out the way to track engagement with communications so that we can do these types of evaluations for all the other great things we're doing in music and prove their value. Thanks so much for your attention, and I'm going to pass it on back to Dr. Dow for our next segment.
Thanks, Christian. So we're going to move into our last discussion here. I'm joined now by Dr. Christian Stensland, who just gave a great presentation, Dr. Ann Sales, Dr. Khurshid Ghani, and then Dr. Kevin Tim. Dr. Kevin Tim is not a urologist, but Dr. Kevin Tim is a great dentist and is a partner advocate for the SOUL trial, and is going to share some insights for us here today. So kind of where I want to start, maybe, Kevin, is with you. Ann presented this really interesting data on patient perspectives around ureteral stenting. Maybe you could share a little bit about your prior stone history, and kind of lean into why you personally felt like participating as an advocate for the SOUL trial was something you wanted to do.
Yeah, I started my stone journey about 15 years ago. I've had, I think, 19 surgeries to remove kidney stones by this point. Some have been easy with single stones. Some have been multiple stones. I've had stents before, stents after, double stents. I've had a variety of different things. Take them out yourself, have them removed back at the hospital. And it's just interesting to see, talking to other patients. I have my own patients who have had stents before too, and nobody's really happy with them. So anytime you can find a reason to not stint and do it safely, seemed like a good place to start a discussion, at least.
And if you reflect on what you heard from the folks you interviewed on the patient side, were there outliers? Did you hear from patients that said, "Yeah, actually, it's not a priority for me. Didn't really feel it. Didn't care. Wasn't a big deal"?
Yeah, we did. I think there's some of those as well. Every person's got their own level of pain tolerance and how much they're, comfortable with. I found stints. I had one in for 3 weeks prior to a surgery. And it just kind of became part of your life. You deal with it. You didn't really have a choice in the matter. It was there. It was for safety. It had a purpose, and you make it work. I trust the doctor's recommendation more than we just don't want to have one, because without one, I would have been in a lot of trouble on many occasions.
Was that your sense too, Ann, and kind of looking at the cohort of patients that you interviewed?
Yes, I think definitely. It was certainly a minority of people who said that some people said, "I don't care," and other people expressed the same opinion that Kevin just did, which is, if my doctor thinks I need it, then I'm okay with it. And that was, I think that was true of most people. If they felt that that the procedure really required it, and that their surgeon felt that that was the right thing to do, they weren't upset about that. I think there is still the issue of trust and understanding that the person who's doing the procedure knows best.
So, Kevin, tell me a little bit more about your motivation for participating, kind of getting behind the curtain into the weeds with this trial as an advocate. What led you on that journey? Obviously I asked you, but it's a significant amount of time for you. What are your motivations there?
Well, everybody's got a story, and I think based on a lot of what I've seen, the education part of it beforehand for patients who have never had a stent was a big part of what we talked about in a lot of the questionnaires and stuff. The first time I got one, I didn't know what it was or what it was doing or why it was there. And so having that education part, we've talked as well about, how to remove them and how that happens. And I think patients need the education. And I think that's the part where I was, hoping to help somebody get a perspective on what it was like to have one, so they know, how the patients are going to deal with this and how the patient's perspective is, so they can go ahead and be properly educated and ready for what's about to happen.
So, Khurshid, I want to bring you in for a second. So, one of the things that I think is most impactful for urologists that are tuning into this webinar is understanding the patient perspectives. I truly don't think that this effort would have been funded without the work that Ann and her team are doing. And so, what are your reflections, kind of understanding these data, the structured interviews, and then your own clinical practice around the patient experience and how that's kind of either changing your practice or reinforcing your practice?
I think the
biggest revelation to me that Dr. Sales and her team were finding is something that we just take so for granted, which is you have a stent and you're going to undergo stent removal. And I think it may have come up by Jan earlier on in the session. She says it's stressful having a stent and it's stressful thinking about when it will come out. And we are a little bit, I think, so immune to this as urologists that you're just going to come to my office, we're going to pull out the stent. What's the big deal? And we learned from Anne's team that they're terrified about what that means. They haven't been educated about the procedure. And so one thing is I'm much more mindful and respectful now about the process of stent removal. And I think as a result of this work, we are, as you know, Casey, Music is trying to create now better videos and guidance on stent removal, educating patients. So educating patients around stent removal is not something I thought would be the first thing, with the biggest patient learning that I have on stent omission is actually the fear and terror of the stent removal in patients who are stented, because many of these patients do get stented, right? And that's what we're learning from some of that. I'll stop there. I have other things, but I want you to reflect on if there's anything else further, or Wilson, or other thoughts on what he's been learning.
Yeah, I mean, I in general completely agree with what you said. I think that we all remember the one patient who you stented that had the most miserable experience ever. And that kind of, I think, was one of the reasons we went down this path. But more broadly speaking, I think what Anne said is really interesting, right? Patients are going to trust what their doctor says and leave medical decision-making and to the doctor's expertise. I think that that's part of the patient-physician relationship, and it's something that we take very seriously. That said, this is a kind of a nice segue for me. And that relationship in this particular scenario is based on our fear that we're going to potentially harm someone by omitting stents, knowing, though, that we all have those patients who are uncomfortable with stents. So maybe tell me a little bit more about what your big high-level take-homes were from interviewing physicians, because I think that's fascinating as well.
Yeah, I think the biggest was that people just expressed a level of uncertainty and discomfort with not using a stent. That omitting a stent means not knowing what's going to happen, even though when we ask them, well, when you have omitted stents, have you had bad outcomes? For the most part, with a couple of exceptions, for the most part, most people said, no, things have gone fine. It hasn't been a problem. But the uncertainty and the concern that there might be a bad outcome, in particular, that there'd be retention of the stone in the kidney, that the ureter blocked, that something else that could be really quite harmful to the patient, outweighs that sense of concern about the patient's well-being and the pain issues, which are the primary issues that patients experience.
And so, Kevin, you've kind of, again, using the analogy of kind of being in the inner circle here, you've been a part of the construction of this study with a very vital voice, which is the patient, right? Can you comment a little bit? I know you're not an enrolled patient in the trial like we had as Janice, but what is your sense from the multitude of phone calls that we've done around how we're trying to educate patients, recruit patients, and how do you feel about that as a patient who suffered from kidney stones?
I think the education part is always going to be the key. I mean, if they don't know even what a stent is, then they don't know why they wouldn't want one. And if they've got one and they're uncomfortable, what can be done? And if they're going to have it taken out, how is it going to be taken out? Because there's a couple different ways that can be done too. The uncertainty, which I think Janice talked about too. When is this happening? How is it going to happen? What's it going to feel like? All of those things create the, one of the questions in the earlier part was atraumatic. How atraumatic is traumatic? Or, in our minds as patients, it gets so much worse than what it really is. And then sometimes you go in and they pull the stent out. I mean, you removed my first stent. It was, 3 or 4 minutes or 5 minutes. It wasn't a very long procedure at all. And I'm like, oh, that's it. But then I've had other, stints that were much more complicated than that. So having an expectation and educating ahead of time is kind of always my thing. I mean, if you tell them about it ahead of time, it's information. If you're going to tell them about it afterward, it may sound like an excuse.
Yeah, that's insightful. I think one of the things that keyed in on Anne in your closing, and I want to bring Christian into this conversation. You'll forgive him. He's a urologic oncologist, so has no business being in an endourology webinar, but his clinical expertise extends far beyond that. But Christian, I think the question that we're all then left with is, let's say we conduct the best, clinical trial possible. We've gotten the patient voice, we've done things right, and we show that, perhaps stent omission is not harming patients, right? And that on the flip side, that patients are actually really uncomfortable with stents. How do you then go back to urologists and implement something like this? And I know, Anne, you're a world-renowned expert in this same space, but Christian hasn't said anything yet. Where does your expertise, Anne's expertise, fit into that sort of the discussion? Because that's really where the rubber meets the road. You can do the best study ever, but if everyone says, yeah, I'm not going to do that, then where do we go?
Yep. Yeah, it's a great point. Thanks. I will add, I have actually enrolled to the SOUL trial during my limited clinical time, despite my urological oncology training. Yeah, that's it. Yeah. Putting my money where my mouth is. But yeah, it's a great question. I feel like, as Anne knows, as one of my mentors in implementation science, a lot of this is even if you have great randomized trial data, it either never gets implemented or it takes years and years and years to get it in place. And so this is part of the rationale, as you know, for the SOUL trial itself, of getting designed to give outcomes and inform data on things that are important to all the stakeholders. So urologists who are ultimately making the decision in the OR to put a stent or not. And why is that? And what are, as we say, the barriers and facilitators? So what's leading to us putting a stent in, what's stopping us from putting a stent in, or the reverse of what's keeping us from leaving it out or doing it, what's encouraging factors, and then how do we test the different strategies? If you say, it's that people don't understand, we're not understanding the patient perspective enough for things like how painful a stent can be or the anxiety surrounding it, then that informs or it implies a certain strategy that then we can say, well, maybe we need to do some type of an educational intervention to give that perspective to urologists, and then decide how valuable is that? And when we deliver that, if you only have a certain amount of messaging you can give, what's going to be most effective? And that's regardless of what the results of this trial are, which is really nice and a great transition point in that sort of last leg of this is figuring out whatever we find, how do you get it into the hands of the people who need it? And again, getting stents where we need them and not where we don't.
Yeah, and if I can bring in Dr. Sales here on this, I mean, we had this discussion and you gave a very insightful comment, and about it's a training thing. And we heard that from Wilson. We heard that from John. Mm-hmm. They didn't train, they didn't know how, then they got trained and they know how. And you said, and if this is if the trial's findings are as we hypothesized, then the AUA and the associations, the Urological Society we have to be some implementation steps on how to train people to do stent omission. What do you think?
I totally agree with that. And I think, training, what underlies training is people's self-confidence and their sense that this is something that they can do comfortably. It's that sense of uncomfortableness that I think drives a lot of decision-making, especially in a situation like an operating room procedure that's underway. You've got time pressures on you to get the procedure done, to do it well. And your decision is going to very much depend on what you know and what you're comfortable with. So if you've not received training, then it's very unlikely that you will decide to omit a stent unless you feel 100% sure that this is an entirely uncomplicated procedure. And that's rare. It's unusual not to feel some level of discomfort and look at the situation you have and think about it and decide, I want to be comfortable. I think I'll do the thing that seems safest.
Yeah, I mean, well said. I think what I take from this is that, we've done a tremendous amount of work getting things to this point. Kudos to Khurshid. And I should say, from reflecting on your slides, Christian, a lot of those initiatives came organically out of the team that is running the SOUL trial, which by no means is just myself and Khurshid Ghani. But people that attend a 20-minute meeting. There are people that are living this, 7 days a week to recruit patients. Think of ideas like Solvember, Soul Madness, et cetera. So it goes without saying that we couldn't be doing this without them, but really the work's just begun, right? We hope to conclude this trial, but really it's going to be where we go from here, and help from experts like yourselves and the input of our great patient advocate, Kevin Tim, where we're going to be able to take this to the next level. So thank you to our panelists. I'm going to move just kind of into some brief take-home messages here. It's really hard to distill down, what was a tremendous hour and 15 minutes of content here. But I think as I'm reflecting on where we're at currently with the SOUL trial, my hope and I think my strong feeling is that the conclusions of this trial are going to provide high quality evidence regarding the safety of stent omission, whether it be one way or the other. I think it's going to inform practice, and I think that's key. I think we heard very well from two urologists who trained in very different ways that you can embark on your journey to stent omission with easy cases, right? Start with the low-hanging fruit. Don't choose the most complex cases to begin to attempt stent omission. But do realize, as you're going down this path, the data has suggested time and time again that while it is a fear or uncertainty, Anne said multiple times from our physician interviews, it is a lot of uncertainty, but it may be unfounded, right? Obstruction and need for stent placement in the setting of stent omission is very, very uncommon. In the music literature and in others, it's far less than 1% of the time. So take comfort in that fact, especially as you're using some of these more straightforward cases. We heard time and time again and had some great videos from Dr. Gupta around the idea of smaller scopes, specifically the 6.3 and 7.5 French disposable scopes, or reusable scopes for that matter, that may facilitate stent omission. These are definitely things that I'm employing in my practice with great results. I think it removes some of that uncertainty for me personally, and I think we heard that was probably the case with Khurshid and others. It is pretty clear to me, and based on the results that Anne has conveyed today, that most patients prefer stent omission, not all, but most. But we do recognize that our own clinical biases as physicians and uncertainty do result in stent placement. And so these are things that we need to balance as clinicians, but also need to hear when patients come to us. And then finally, I think, Christian, you did an excellent job highlighting that trial recruitment is challenging. We are surrounded by an incredible team that is going to get this trial over the finish line. But we are and will continue to pursue innovative ways to maintain accrual so that we can complete this, I think, potentially groundbreaking clinical trial. So a couple last minute things. This is just housekeeping. Thanks to all folks who attended here via the webinar. Do take a screenshot of this or use the QR code. I'll leave this up here for a second to claim your CME for spending the evening with us. You do need to claim your credit by Wednesday, November 5th. So you've got a week. And I think that we can probably share this via email to folks who registered in case we've missed it. And then kind of last, but certainly not least, this work within SOUL, but certainly in the broader context of music, which by no means only involves kidney stones, but also a fledgling BPH initiative, small renal masses, and prostate cancer, really does take a village. And myself, Khurshid, Wilson, Dr. Borza, we're all really just, shepherding a great group of people that are really just knocking this whole thing out of the park for our patients in the state of Michigan and for practices across the state of Michigan as urologists. So I'm humbled to work with all these people, and without you, none of this would be possible. And so congratulations to the team, and thanks to all of you who gave us an hour and a half of your evening tonight. And please do take care.